Hello, my name is Dr. Jeff Heimiller. I'm a faculty in the Department of Emergency Medicine at Vanderbilt University Medical Center. This video is a refresher on anatomy and physiology of the eye and focuses on structures important to the practicing emergency physician. This video will help you prepare for the emergency ophthalmology workshop. When we refer to the eye, we are specifically talking about the eyeball and the attached optic nerve. The term orbit refers to the bony cavity that surrounds the eye and its supporting structures. The orbital region refers to the soft parts anterior to the orbit and eyeball, including the lids and ducts. The eyelids protect the eye from injuries such as trauma, caustic chemicals, or light. They also provide the cornea with moisture, nutrients, and oxygen by spreading lacrimal fluid over the eyeball. Externally, the lids are covered with skin. Internally, they are lined by palpebral conjunctiva. That same layer is continuous with the conjunctiva covering the eyeball, where it is called bulbar conjunctiva. Where palpebral and bulbar conjunctiva meet, you have superior and inferior conjunctival fornices. The eyelid shape comes from dense plates of connective tissue called the tarsal plates. Behind the tarsal plate lie the structure of the orbit, including multiple fat pads. An eyelid laceration with eviscerated fat suggests a tarsal plate injury and globe injury. Ophthalmology should be consulted for these findings. You also see here that the lids are lined by a number of different glands. This will be important for you because these glands occasionally get clogged, causing hordeola or chalazions. They can also become inflamed, resulting in blepharitis. The orbital septum is a fascial layer connecting the lid margins with the bony orbit. This layer separates the orbital and periorbital spaces. Infection anterior to this layer, called preseptal or periorbital cellulitis, can be treated much like many facial infections. Orbital cellulitis, or infection deep to this fascial layer, is a true emergency, warranting IV antibiotics and immediate evaluation by an ophthalmologist. The lacrimal fluid, commonly called tears, provides nourishment to poorly vascularized parts of the eye and can add a heightened sense of drama to cheesy movies. This fluid, produced superior lateral to the eye, washes inferomedially across the eyeball, helped along by the blinking of the eyelids. If a patient loses the ability to close their eye or blink, it leaves the cornea and sclera exposed and malnourished, predisposing to injury. At the medial canthus, the fluid drains into the lacrimal sac and then through the nasolacrimal duct. These structures can become blocked or infected, resulting in conditions like dacrocystitis. Extraocular movement testing assesses 6 muscles innervated by 3 cranial nerves. Aside from cranial nerve 4 innervating the superior oblique and cranial nerve 6 innervating the lateral rectus, everything else is served by cranial nerve 3. The rectus muscles each pull the eye in their own direction. The superior and inferior obliques pull the eye inferomedially and superior-medially, respectively, and also rotate the eye. These 6 muscles generally become important to us in the case of nerve palsies and muscle entrapments. Orbital injury can cause any of the extraocular muscles to become entrapped, preventing the eye from moving in a direction opposite that muscle. Inferior rectus muscle entrapment is the most commonly seen in the setting of orbital floor fracture. This CT image demonstrates an orbital floor injury with orbital contents, likely the inferior rectus pushed through the floor. The clinical image demonstrates entrapment of the right eye during upward gaze. The eyeball can be divided into 3 layers. The most outer layer consists of the cornea and sclera, which meet at the limbus. The sclera is the white of someone's eye, as the overlying bulbar conjunctiva is normally transparent. The cornea is the transparent anterior part of the fibrous layer, which is entirely avascular. This means it needs to get food and water from surrounding blood vessels, and the lacrimal fluid washing over it and aqueous humor flowing under it. The cornea is also highly sensitive to touch. Your patients will confirm this with the severe pain they experience from corneal abrasions or ulcerations. Note the limbus here, which is a 1 millimeter wide ring around the cornea, where cornea, sclera, and bulbar conjunctiva meet, and where several other structures are anchored to the eye. When the eye is red or injected, limbic involvement or limbic sparing can provide important information about what structures of the eye are inflamed. Next is the middle or vascular layer, made up by the choroid, ciliary body, and iris, which is largely charged with nourishing and protecting the rest of the eyeball. The largest component is the choroid, which lies just inside the sclera and is jammed full of blood vessels. Just deep to the limbus, we find a ring of vascular tissue called the ciliary body, which is what the lens is anchored to and what controls the shape of the lens. This is also where aqueous humor is produced, which we will talk about a little later. This vascular layer then continues onto the iris, which lays over the lens, narrowing and widening to regulate the amount of light reaching the retina. Collectively, these structures are known as the uvea. We might therefore refer to inflammation in this layer as uveitis, or we might refer more specifically to the individual components using terms like iritis. Moving more interiorly, we find the third layer of the eye, consisting of the retina. This contains both visual and non-visual layers. The fundus is the posterior part of the eyeball where all that light is perceived. Note here how the macula, the area of the fundus with the most concentrated visual perception, is in line with the visual axis of the eye. This means that light entering through the cornea and passing through the pupil will be focused on the most sensitive part of the retina. If the retina becomes detached from the choroid, known as a retinal detachment, it is especially important to know whether the macula is involved, as this will be the biggest determinant of visual loss for the patient. Note the optic disc located medial to the macula, where the retina mates with the optic nerve. Although the optic disc itself has no light-sensing abilities, this is where the nerve fibers and vessels coming from the optic nerve enter the eyeball. As light passes through the eye toward the retina, it passes through several other important structures that can cause patients to lose vision. The cornea that we already talked about is responsible for most light refraction, but we also have the aqueous humor, lens, and vitreous humor. The aqueous humor, created at the ciliary body, occupies the anterior segment of the eye, which is divided into anterior and posterior chambers. Aqueous humor produced at the ciliary body flows through the posterior chamber, sneaks between the iris and the lens into the anterior chamber, and bathes the avascular cornea in nutritious goodness before being drained out through the canal of Schlemm. Now take a look at that angle where the anterior surface of the iris meets the posterior surface of the cornea. This is where all that aqueous humor is drained from. The balance of inflow and outflow of aqueous humor determines the intraocular pressure. If the iris thickens up in this angle, as it does when the eye is suddenly dilated, that angle narrows and can be totally blocked off, resulting in a sudden rise in intraocular pressure seen in acute angle closure glaucoma, which is one of the causes of a painful eye that can result in rapid and permanent vision loss. The lens is the elastic encapsulated structure that allows us to further refine the focus of light that began at the cornea, constantly fine-tuning the focus of our vision. It is suspended immediately behind the iris by zonular fibers that attach it to the ciliary processes, allowing it to become more flat or round as needed. Occasionally, blunt trauma to the eye can disrupt the fiber suspending the lens and it can be dislocated. Unlike a shoulder, you probably shouldn't try to reduce this yourself. And lastly, after light passes through the lens, it then travels through the vitreous body, a sac filled with watery vitreous humor. This sac of fluid provides support for the eye, keeping the lens and retina in place. Although bleeding in the vitreous will disrupt vision for many of our patients in the short term, note that it is separated from the more fragile light-sensing retina, and bleeding or detachment of the vitreous usually resolves without lasting visual deficit. Testing visual acuity provides a great review of the structures we just talked about. When we have a patient read an eye chart like the one at the right, that image needs to pass through a clear cornea, and that cornea needs to be malleable enough to start the process of focusing the image. Next, it needs to pass through the anterior chamber, which needs to be free of debris like inflammatory cells or blood. We then need the ciliary muscles to be able to shape the lens for more refined focusing of the image, and the iris needs to be able to control the amount of overall light coming through. Now, that focused light needs to pass through the vitreous, where blood or deformation of the vitreous body could also deform the image, as in the case of vitreous detachment or hemorrhage. Ultimately, that image is received by the retina, which needs to be appropriately located and adequately perfused. Disruptions anywhere along this process can result in decreased visual acuity, so this simple test is incredibly powerful as a screening tool. But even if the eyeball itself is able to shape and receive that light appropriately, it still needs to be perceived by the brain. The optic nerves carry all of that visual information back to the lateral geniculate nuclei and then on to the primary visual cortices. Note that information from the nasal portion of each retina crosses at the optic chiasm to the contralateral side, so the left visual cortex is perceiving the right visual field from both eyes. By testing visual fields, we can help pinpoint lesions to different regions. If there's an injury to the optic nerve, it will knock out vision to the ipsilateral eye, but vision in the contralateral eye will be unaffected. Because the fibers from the nasal aspect of each retina cross at the optic chiasm, a lesion here will cause deficits in the temporal visual fields of both eyes. And a lesion in the left or right visual cortex will cause a visual field cut in the contralateral visual fields of both eyes. Now we have the knowledge to understand the pupillary response. When everything is functioning as it should, light shined in either eye is perceived by the retina, and that information is transmitted afferently via the optic nerve to both visual cortices. Then, efferent signaling down the oculomotor nerves sends signals back to the ciliary muscles of both eyes, and the pupils constrict. If there's a loss of light perception or disruption of the afferent processing of that signal, the patient will have a relative afferent pupillary defect, as this patient is suffering in their right eye. At top, their pupils are appropriately dilated in a dark room. When we shine a light in their left eye, both pupils constrict as they should, meaning they are able to receive light from this eye and then tell both pupils to constrict appropriately, with functioning ciliary muscles and irises. But when we shine a light in the right eye, both pupils dilate again, as if they're back in a dark room. Because we proved in the last step that the efferent system is functioning well and the pupils are able to constrict appropriately, we know the patient here is unable to receive light from the right eye as well as they were from the left. This is called a relative afferent pupillary defect, or Marcus gun pupil, and it's almost always due to something bad, like a devastating retinal or optic nerve injury. Well, that concludes this short primer on anatomy and physiology of the eye. There is so much more to know and learn about the eye, as is evidenced by the fact that people do entire residencies and fellowships on this one organ. But I hope this is enough to jumpstart your learning during the ophthalmology workshop. And as with everything you'll encounter over the next 3 years, mastery comes with practice. So get out there and apply this stuff on your next shift.